Great.
Actually, Shelly's name is not on that slide. Alana, do you mind just introducing her as well?
Yeah, definitely.
Shelly University.
Okay.
Anna, do you want us to keep up on the chats while you're moderating like last time?
Yeah, that would be super helpful. I'll try to give them some attention as well, but that's definitely helpful. And then if you have any questions or problems, technical problems, just put it in the, we started a WhatsApp thread. I'm not sure if you saw that, Julia.
Mm-hmm.
But we can.
A separate one for technical or just, or the main one?
I just started it this morning, just for this.
Oh, okay.
This group of panelists, yeah. Or you can text me directly, Cell too.
Okay, hello everyone. Welcome to Oxygen Therapy and Critical Care, the case-based series. Today we are happy to present session number 8. The topic is high flow nasal cannula and non-invasive positive pressure. We have a number of panelists here today, starting with Dr. Anna Maria Crawford from Stanford University in the USA, Dr. Shelley Porter from Stanford University in the USA, Dr. Freddie Ariza Cadena from University del Valle in Colombia, Dr. Jean-Claude Uwimana from Kibagora District Hospital in Rwanda, Dr. Julia Weinkoff from Minnesota in the USA, and Dr. Rediet Shemaliz from Gandhi Memorial Hospital in Ethiopia. Before we begin, we do have a couple of etiquette and housekeeping items to go over. To begin with, our programming is based on a foundation of love and respect. Please respond kindly rather than react if you disagree with something. It is everyone's responsibility to keep this webinar a safe space. We will be using the chat function for question and answer. To participate, the button for question and answer is at the bottom of your screen. Please send all questions through the chat box and feel free to introduce yourself. We also invite you to turn on your video. Position your webcam effectively to show your face, if alone, or to capture the whole group. If you have any technological issues, please send us a message through the chat and our ECHO IT team will be here to support. This session is also being recorded and your attendance is consent to be recorded. Thank you. And finally, please be mindful of infection prevention and control. Try to limit the numbers of people joining from a single gathering place and practice physical distancing. The last thing that I'd like to share before we begin is that we do have interpretation available today in both French and Spanish. To access this, you do need a new version of Zoom, and you can choose to mute the English part of the session, or you can listen to both, in which case the translation will be louder than the speaker. And so as you can see on the screen, the interpretation button is at the bottom of your Zoom screen. And so with that, I'll pass it on to Dr. Anna Maria Crawford to begin.
Thank you, Alana. Good morning or good afternoon to everyone. Welcome to part 8. This session will discuss high flow oxygen therapy and non-invasive positive pressure. And as per usual, everything will be done in a case-based discussion. So we're going to use the Learning Resource Center in order to run the content of the discussion. So I'll share my screen. This is the Global Anesthesia and Critical Care Learning Resource Center. Anyone can create a free account. You do have to sign in, but you can see there are multiple courses on the learning platform. There's a COVID course, an ICU course, and today we're going to go into, and then there's several other courses below. Today, we're going to go into the oxygen series. The link to this website is in your chat box. It will work both on your computer and on your phone. We're going to go into the second section called Oxygen in Critical Care, the case-based discussion series. And we're going to go down to part 8. You can see all of our previous sessions listed above, each with videos in English, Spanish, and French. And part 8 today is high flow nasal cannula and non-invasive ventilation. Once you click on that, you do have to sign in. Again, the account is free. And you can see again on the left-hand side a navigation pane, which I'm going to close out so that we can see the session in full. And I'll make this go away as well. One of the first things I want to point out is there's a small paper clip up in the right-hand corner here. If you click on that paper clip, you can get a PowerPoint presentation. So this presentation in slide format that's freely available and you can download it on your computer. Today, we're going to discuss Mr. G, who's a 39-year-old male who presents with tachypnea and hypoxemia. And we're going to discuss high flow oxygen therapy as well as non-invasive positive pressure for adult patients. Next month, we have a session exclusively for pediatric patients. So today we'll be talking about adult patients only. There are two things of which I want to make you aware, our disclaimer and our pledge to our learners. We want to remind participants that discussions and content on the LRC serve to promote exchange of knowledge and experiences of healthcare providers. Discussions are in no way intended to substitute for clinical judgment and independent decision-making of qualified healthcare professionals. Administrators of the LRC make every attempt to provide up-to-date and accurate information. However, information changes rapidly. Individual healthcare providers are responsible for adapting information to fit availability of resources and standards of care in their own institutions. And we have a pledge to our learners. We believe education should be free and free of interests and conflicts. The Global Anesthesia and Critical Care Learning Resource Center aims to bring high-yield, evidence-based, peer-reviewed resources to learners regardless of resource setting. We pledge to keep education open access, and we pledge to keep education free from advertising. We pledge to uphold ethical standards and pledge to approach all learners with compassion. Assist International is an international nonprofit organization, and the Learning Resource Center has received no financial compensation or advertising incentives other than within these partnerships. So we like to use what we call practice change objectives instead of learning objectives, because most learners can learn information, but it's an exceptional learner that takes action and changes their practice to improve patient outcomes. So our practice change objectives for today, we're going to discuss two sections, as we mentioned, high flow oxygen therapy and non-invasive positive pressure ventilation. When talking about high flow oxygen therapy, we want to understand the upper limit of our low flow devices and differentiate between low flow oxygen therapy and high flow oxygen therapy. We want to understand when to escalate to high flow oxygen therapy. We want to be able to understand the benefits of high flow oxygen therapy and list the possible complications. We also want to know how to titrate the oxygen therapy up and to titrate it down. Then we'll discuss non-invasive positive pressure ventilation, where we want to list the indications for acute respiratory failure. We also want to list the proposed benefits and possible complications of non-invasive positive pressure ventilation. And we'll do this all within a case discussing Mr. G, who, as we mentioned, is a 39-year-old who presents with 5 days of worsening shortness of breath and a dry cough. His breathing is harder when he gets up and walks around, so he's tried to stay in bed and rest. He noticed that his fingers and his toes turn dark blue when his breathing is worse. His past medical history is significant for obesity. His BMI is 35. He has type 2 diabetes and takes oral hypoglycemic medications. His past surgical history includes an appendectomy when he was 20 years old, and he doesn't have any allergies. He works as a house painter and he's divorced with one son who's age 10. He doesn't smoke and he only drinks beer on the weekends. So we're going to start talking about high flow oxygen therapy. But before we do that, I want to remind all providers on this session that high flow oxygen therapy generates viral aerosols. So providers using high flow oxygen therapy must have PPE for contact, droplet, and airborne precautions. It is required. When not wearing a mask, patients with potentially infectious diseases can spread viral aerosols just by speaking, coughing, or eating. Oxygen therapies that use high flow and/or pressure can also generate infectious viral aerosols. High flow nasal cannula is an aerosol generating intervention. Both patients and providers should be in PPE and masks at all times until the risk of infection has been cleared. So our first 3 practice change objectives, we want to understand the upper limit of our low flow devices, and we want to differentiate between low flow oxygen therapy and high flow oxygen therapy. And we want to understand when to escalate to high flow oxygen therapy. So for our first poll question, I'm going to ask my colleague Radhia to help me ask the audience this question and launch this poll, and then we can have a discussion.
Hello, everyone. So this is the first poll question. Which low flow oxygen delivery device delivers the highest FiO2? Is it A, nasal cannula, B, a simple face mask, C, a nasal catheter, D, mask with reservoir bag, E, Venturi mask?
So you can put your answer either in the chat box or you can use the poll that we have launched. And I see some answers already coming in, which is great.
Yeah.
So we'll get ready. We'll give them about a minute, and you can see the timer in the top of the poll. So we'll give them 1 minute to answer, and then we'll tell them the answer and have a discussion.
Okay. Everyone, please participate.
Okay, that looks like a minute to me. So it seems like most people are saying the mask with the reservoir bag. What do you think? Radhia, you're muted.
So about more than 60% have mentioned that it is mask with reservoir bag. That's correct. I agree with that, but let's discuss on that one.
Okay.
The next.
So I just want to remind everyone that within the Learning Resource Center, if you see a question such as this one, you can click on that question, especially if it says click, as you can see here, and it will take you to a resource, an article, a table, a video, some sort of resource that you can use to find the answer. And so this one takes you to actually another section on the Learning Resource Center with the different oxygen delivery devices.
Yeah.
So we can start with the nasal prongs if you want to tell us about that.
Okay, so we've got nasal prongs, as you can see from the picture, or some people call them cannula. The type of patients that use this can be adults or children, and the flow of oxygen that is delivered through nasal prongs or cannula is about 0.5 to 5 liters per minute. It can go up to 5 liters per minute. the FiO2, or the fraction of inspired oxygen that's delivered, is about 28 to 40%. So I'm sure most of you have this in your setup and are commonly using it. Got the second one, which is a nasopharyngeal catheter. As you can see that it's inserted in one nostril, and usually we use it for infants and children, and you put about 0.5 to 2 liters per minute of flow of oxygen, and the FiO2 that's delivered is about 45 to 60%. The next one is a face mask. Usually we use it for adults, but both children and adults, and the flow of oxygen that's delivered through this face mask is about 6 liters to 10 liters per minute, and the FiO2, or a fraction of inspired oxygen, is about 44 to 60%. That's a simple face mask. And we've got, most of you have answered this question, the answer, the mask with reservoir bag. We use it for both adults and children, and the flow of oxygen through this device is about 10 to 15 liters per minute, and the fraction of inspired oxygen delivered is about 60 to 95%. You can see how significantly it has increased from the rest of the devices that you've seen so far. That the last one. So they've got the last one called the Venturi Masks. Both adults and children can use it. And there are certain valves attached which are color coded. Sorry about that. Let's see the picture. Yeah. So yeah, there are color coded, as you can see, the blue, pink. According to their colors, the valves vary, and the degree of FiO2 is labeled on each of these attachments. So you are able to choose a degree or the fraction of oxygen the patient needs, and according to the patient's demand, it's able to deliver about 24% to 60%, and it reaches about 4 to 15 liters per minute. These are the Venturi masks.
Wonderful. Thank you so much for that explanation. So the answer to the question then is D, which most people got correct, didn't they?
Yes, that's correct.
So
the mask with reservoir bag, delivers the highest FiO2 among the rest of the devices.
Right. So it can deliver up to 90 to 95%. So that's really the upper level. One of our practice change objectives is to understand the upper limit of our low flow devices. And so the answer to that is really your reservoir bag, mask with reservoir bag. Wonderful. Thank you so much.
I'm sorry, can I interject? The mask with the reservoir bag has to be used with 10 liters a minute or more. So as the patient gets better, you have to change the device if you're going to de-escalate their oxygen. If their oxygen requirements are better, you have to use a different mask, basically. You cannot decrease the liter flow on a mask reservoir bag.
Yes, thank you. Thanks, Shelley. That's an excellent point, that you have to run 10 to 15 liters per minute for the reservoir bag. And if your patient is improving, then you should go down to one of the other devices. So thank you. That's a good point on titrating up and titrating down your oxygen therapy. So wonderful. Okay, we have a case update. Mr. G has the following vital signs. His temperature is 38 degrees Celsius. His heart rate is 99. His non-invasive blood pressure is 107/88, and his respiratory rate is 28. The SpO2 shows 90% on a face mask with reservoir bag at 15 liters per minute. So as Shelley pointed out, that's an appropriate flow for that device, and we'll probably are delivering that 90 to 95% because that's the higher level of flow for a reservoir device. Okay, so our next section, we're going to ask our colleague, Dr. Freddie, to help us. And it's list the signs of respiratory distress in adult patients.
Okay, Anna. Hi, dear friends. Time to invite you to list which clinical signs should take us to consider respiratory distress or respiratory failure in adult patients. So write your answers. While you write your choices, we are going to see a short and representative video of a person with respiratory distress. So people who not familiarized with this type of patients understand the main clinical signs and differences with other pathological conditions.
Perfect, thank you.
As you may see, significant respiratory effort is evident in these patients, as intercostal retractions and thoracoabdominal asynchrony are persistently seen. Respiratory rates not too high may lead us to causally conclude that this patient is improving as severe starvation of ventilatory efforts may be close to the collapse. This is a very good example of respiratory failure, patient having troubles. So let's see the chat, Anna.
Wonderful. Dr. Freddie, it's a little bit difficult to hear you while the video is playing, but we have some good descriptions coming in the chat box.
Oh, yeah. Are you listening to me now?
Yes, sir.
Yeah, okay. This is a typical patient with a short respiration and respiratory effort, a representative video of a person with respiratory distress. So people who don't familiarize with this type of patients understand the main clinical signs. As you may see, significant respiratory effort is evident, but breathing rate is an increase in the number of breaths per minute may mean that a person is having trouble breathing or not getting enough oxygen. The color of skin changes, grunting, nose flaring, and one detail of the video, retractions. The chest appears to sink in just below the knee or under the breathstone. Breathbone with H-breath or both. This is one way of trying to bring more air into the lungs. Sweating, but this is a special sweating, but that is not, the skin may feel cool or clammy. Wheezing and body position. A person may spontaneously lean forward while sitting to help take deeper breaths. This is a warning sign. This is a warning sign that he or she is about to collapse. Dr. Anna.
Wonderful. Thank you, Freddie, so much. So the audience can, again, click on this question box to see more answers to the question. But in the chat box, I just want to say that everyone did a really great job. The chest end drawing, accessory muscle use, the abdominothoracic respirations, meaning that the stomach and chest are moving in different directions, tachypnea, restlessness. Someone listed nasal flaring, which can also be seen. It's not seen in this video because he's actually wearing a non-invasive positive pressure mask, but all of these intercostal recessions and oxygen desaturation, all of these are really great answers. So those are the signs and symptoms of respiratory distress in adult patients. The next question I'd like to ask Shelley Porter. Shelley is a respiratory therapist, so a specialist in respiratory care for patients. In some countries, we don't have respiratory therapists, but we do have what are known as physios, and physios will often do a similar skill set. So Shelley, some people may think that high flow oxygen therapy or high flow nasal cannula is really just using a nasal cannula at higher flows. And so I was hoping you could help us understand a little bit more about high flow nasal cannula by discussing this true false question.
Okay, true or false? High flow nasal cannula is oxygen delivered through a standard nasal cannula at flows greater than 6 liters per minute. Well, that is false. High flow nasal cannulas are specially designed to provide oxygen at greater than 6 liters a minute. You cannot use a regular nasal cannula. The picture in figure 1 shows the tubing of the high flow nasal cannula, and you also see what's called an active humidifier at the bottom. High flow nasal cannula systems should provide a pretty precise FiO2. It should provide heat, and it should provide moisture and a flow rate. And so when we think about it, normal inspiratory flow rate is between 20 and 30 liters per minute. So when we inhale, we are inhaling at a rate of about 20 to 30 liters per minute. And a high flow nasal cannula system is a system that should meet or exceed the normal flow rates. And a regular nasal cannula at 6 liters per minute does not do that.
Right. And I thank you for that, Shelley. And I think it's important to realize that the nasal cannula being used and the tubing being used is very specialized. So we have found this video online that we think explains high flow oxygen therapy really well. And for the sake of translation, I'm going to play the video, but slow it down so that it's
So what is
not so fast. So my translators will not be upset with me. So the playback speed, I'm going to slow down to 3/4, so 75%. And we'll watch this video. Should only take us about 6 minutes, but it's an excellent explanation regarding high flow therapy.
high flow therapy? High flow therapy is when oxygen is being delivered to the patient at a flow rate that meets or exceeds their inspiratory flow demand. What does that mean? Well, did you know that at rest, the average adult will inhale at a speed of 20 to 30 liters per minute? In other words, if someone was standing next to you right now with a radar gun pointing at your nose, capable of measuring how fast you're inhaling while you're relaxed, the speed at which you inhale would be at around 20 to 30 liters per minute. So high flow therapy should be capable of matching the inspiratory flow or even exceeding it. If an oxygen device delivers less than the patient's inspiratory flow, then the delivery is called low flow. So because the average adult who is at rest inhales at a speed or flow of 20 to 30 liters per minute, a high flow device should be capable of delivering at least that much. Now, in order for this high flow of oxygen to be comfortable to the patient, the oxygen should be heated and humidified to maximize patient tolerance and comfort. And sometimes you'll see high flow therapy described as heated and humidified high flow oxygen therapy, or heated and humidified high flow nasal cannula, or to keep it short, it may be referred to as HHFNC or HFNC or even HFOT or HFT or some other variation of that. More recently, Vapotherm has chosen to refer to their heated high flow therapy as HVNI. They've even tried to describe HVNI as mask-free NIV, but don't get thrown off. On the FDA's website, it clearly identifies their device type as high-flow humidified oxygen delivery device. Now, like other high-flow devices, they deliver a high flow of oxygen and it is heated and humidified to help meet patient comfort and tolerance. And some devices, like Vapotherm's Precision Flow, go up to 40 liters per minute. Others, like the F&P Airvo 2, go up to 60 liters of flow, while still others can go even higher. Because at the end of the day, we're just trying to meet the inspiratory flow of a patient And when that patient is in respiratory distress, that inspiratory demand can be as high as 100 liters per minute. Yikes. So should high flow therapy be a replacement to other forms of therapy like non-invasive ventilation? The answer, absolutely not. High flow oxygen delivers just that, a high flow of oxygen. But sometimes patients have issues with CO2 or ventilation, and not just issues with O2 or oxygenation. NIV is effective for both oxygenation and ventilation. This is why HFT and NIV are often used together on some patients in a complementary fashion. For example, some patients may be on high flow therapy but require more support. Clinicians sometimes escalate to NIV to prevent, if possible, intubation and invasive mechanical ventilation. And if a patient is on NIV and can tolerate short breaks, clinicians sometimes switch to high flow therapy to allow the patient to have that temporary break from NIV where they can eat, talk with their relatives, take an oral medication. You get the idea. In fact, in a Vapotherm-sponsored study, there were 104 patients who presented to the ER in respiratory distress, and they were initially placed on high-flow oxygen. Of those 104 patients, unfortunately, 27 of them failed. And of the 27, 4 were immediately intubated. But the other 23 patients were switched from the high flow oxygen to NIV. And of the 23 patients who failed with high flow oxygen and were switched to NIV, 20 of them improved and did not need further escalation to intubation. In fact, in another study, patients at high risk of post-extubation failure were placed in one of 2 categories. The first category was high flow therapy only, and the other group allowed for both NIV and high flow therapy. Now, the patients that went on both NIV and HFT had a significantly lower rate of reintubation versus the group that went on HFT only. So don't get confused. HFT is definitely not mask-free NIV. But it is a great tool to treat patients with oxygenation issues who are in respiratory distress. So just a quick final summary on high flow therapy. High flow oxygen therapy usually delivers oxygen at a flow rate equal to or higher than the patient's actual inspiratory flow rate. It should be heated and humidified for patient tolerance. And depending on the flow rate and the seal around the nose and mouth, high flow oxygen may create a Cpap effect, although we don't know exactly how much. It also may wash out some CO2 that is in the upper airway, which is often referred to as CO2 dead space washout. But again, we don't know exactly how much. So that's your quick introduction to high flow therapy.
Okay, great. So that's a good video on introduction to high flow oxygen therapy. But now we have a case update. Mr. G, despite receiving oxygen by mask with a reservoir bag, he continues to have a fast respiratory rate or tachypnea. His respiratory rate is now 36 breaths per minute, and his SpO2 or oxygenation has fallen to 88%. The bedside provider decides to place him on high flow oxygen therapy. So this brings us to our next set of practice change objectives. And I'm going to ask my friend and colleague, Dr. Weinkauf, to help me list the proposed benefits of high flow oxygen therapy, list the possible complications, and how to up-titrate and down-titrate oxygen therapy. Julia, would you mind helping us with the next questions?
Good morning, sure. Do we want to give people a chance to respond in the chat of some benefits?
Everyone could, yeah.
Why don't we give a minute? People, please respond in the chat and see what you would say that some of the proposed benefits of high flow oxygen therapy are.
So we'll look in the chat box for your answers. Benefits of high flow.
So someone said avoid the risks, some of the risks associated with mechanical ventilation, such as barotrauma. Someone else said patient comfort, that it's more tolerable than non-invasive ventilation. Avoiding intubation in hypoxic respiratory failure. We'll give just 10 more seconds. Anyone else? Someone said that it can give some Cpap, some continuous positive airway pressure, which is also referred to as a Peep effect. Someone else said washing out dead space, improving comfort. Great, so I think people got a lot of them. Yeah, most of the benefits come from the fact that we can't turn up the flow rate anymore on the oxygen devices that we're using. You know, as I think it was Reddy, it went through, once you maximize the oxygen rates on the other delivery devices, we can't go any higher. So high flow oxygen therapy allows us to go even higher, but compensates for some of those drawbacks. So one big one is that you can add humidification and heating. So as we go up on our flow rates, for example, in nasal cannula, the drying effect of all of that high flow is very uncomfortable for patients and can lead to things like nosebleeds and desiccation of secretions. So humidifying and heating the air allows us to go up higher on the flow rates, which supports oxygenation better. There is that high flow rate then does deliver a small amount of a Cpap or Peep effect, and also washes out a little bit of dead space in the upper airway. But as the video mentioned, we don't know exactly the effects of that. It's been hard to measure. And so it's probably small to moderate at best of those effects. It also is more comfortable for patients because of that heating and that humidification, and also the prongs on the nasal cannula are softer. Several people mentioned the advantage of avoiding mechanical ventilation, and that is something that's been shown in high flow oxygen therapy. It has been shown in many studies that it does avoid intubation. It decreases the rates of intubation. But the strange thing is that hasn't really played out as far as improving outcomes or mortality. So it's a little bit of a question still in critical care, what the exact advantages are of this. But most people that use it clinically certainly believe in the advantages.
Wonderful. Thank you, Julia.
Should we move on to complications? I think that's my part as well.
Yeah, that'd be great. Thank you for doing that.
Yeah, so if anyone has any comments on the benefits, you can sure throw that in. And then also let's give a minute to talk about the complications. Someone mentioned barotrauma up above as far as mechanical ventilation goes. So that's one thing. Yep, and someone else just wrote barotrauma. What about other potential complications of high flow?
Santiago lists gastric distension, nasal dryness, and eye injuries.
Delayed intubation, someone said. Noise, I like that one.
That's a good one.
Yeah. Nosebleed, oxygen toxicity, blindness. Great answers.
Very good.
10 more seconds. Anyone else? Hyperoxygen complications like toxicity, aerosolization of viral particles, just like Anna mentioned before. Absorption atelectasis. Great, yeah, so nothing we do is without complication, right? So some of the complications of high flow oxygen therapy, there is a small risk of barotrauma, but most people feel like it is very small compared to the risk of barotrauma that comes with mechanical ventilation. So it's thought to be an advantage of high flow oxygen therapy. So that is one thing. Also, the high rates of oxygen flow can get pointed up towards the eyes, as a couple people mentioned. So if you have a patient that can't adjust their own prongs, or if the nurse can't be with them minute to minute, it has caused problems with drying out of the eyes, leading to corneal abrasions. It is an aerosolizing procedure, so it can increase your chances of communicating airborne illnesses like COVID and the other ones. It can increase abdominal distension in people who are not able to, burp and control their airway as much. And it can then predispose to people vomiting. And so it's thought that people should have some ability to control their airway and have intact mental status to be on high flow nasal cannula to try and avoid some of those complications. And then someone else said one of the complications is it can delay intubation. And that is something that a lot of people talk about with high flow and other forms of respiratory support, is you may fail to recognize someone who is getting worse or someone who is so ill that they should be escalated to other forms of ventilatory support like intubation. So it just has to have, you just have to have a higher sense of awareness of these patients to detect when they might be failing and when they should have escalation to a higher level of care.
Excellent. Thank you so much, Dr. Julia. I did want to point out one useful resource to the audience, which is up to date. And if you click on both of these question boxes on the LRC, that's where you will be directed. And up to date usually requires a subscription, but during the pandemic, they have allowed some of their ARDS and relevant resources to be accessible for free. And then also you can qualify for a free or discounted subscription, especially if you live in a lower middle income country. So you can click on this link here to see if you can get that subscription for your institution. And then I just wanted to share a personal experience with high flow oxygen therapy. And this picture is of an actual patient that had ARDS from COVID-19. And you can see extensive subcutaneous emphysema. And you can also see perfect outlines of the heart and aorta, and that should not normally be visualized on a plain film chest X-ray. But because the patient had pneumomediastinum and subcutaneous emphysema, you can see that. And you can also see a small right-sided pneumothorax. And so this patient was only on high flow oxygen therapy, was not on a mechanical ventilator. And so you can see some barotrauma with these patients. Probably when they enter the fibrotic stage of their ARDS, their lungs become more stiff. And this patient had just air under the skin all over their face. And as some of the participants mentioned, even in the periorbital space with the eyes. So we have another question, and I'm going to ask my friend and colleague Jean-Claude to help us with this next one. Jean-Claude, are you with us? He's connecting to audio. So give him just a second. Marajo, you're on mute. Jean-Claude? I can see him. Give him just a minute to unmute, and he will help us with this next question. Okay, Jean-Claude, I think you're good.
Yeah. Hello.
Hello.
Yeah. So I had a problem with connection. So.
Taki bazo.
Yeah. I'm happy to see the response from the participants about the 3 parameters that must be set on the high flow oxygen therapy.
So we can have them list the answers in the chat box, the 3 parameters that you must.
Yes, yeah, sure. Mm-hmm.
We have some good answers coming in already.
Mm-hmm.
I see flow rate, flow rate, flow rate. What else?
Okay.
Saturation de oxígeno.
Mm-hmm.
Ah, that's a good one. Flow rate, FiO2, and temperature. What do you think of that, Jean-Claude? Is that a good answer?
So, yeah, they are good answers.
Good.
Yes, yeah. So, as you see, we have to, for high flow nasal cannula therapy, we have to set the flow rate, the FiO2, and as well as the temperature.
Okay. Do you want to do this, launch the next video, Jean-Claude?
Yes.
Okay. We'll do the same thing where we'll turn on the closed caption so that the translators can read along with us. Might be easy. It's
Yes.
English.
Mm-hmm.
Okay. Okay, here we go. 4 minutes.
In this video, we talked a little bit about what high flow therapy is. In this video, we'll quickly highlight the clinical application of high flow oxygen therapy. We already discussed that high flow therapy is not a replacement for non-invasive ventilation because it is not capable of providing the same level of support like NIV. In high flow therapy, for setting, no Peep or Cpap setting, no backup respiratory rate setting, no inspiratory time setting, no patient ventilatory alarms. You also cannot monitor the tidal volume, the IE ratio, and there are no loops or waveforms. You get the idea. NIV, on the other hand, can provide all of these. In fact, the only 2 main controls on high flow therapy are FiO2 and flow. Let's look at FiO2 first. This is typically adjusted to maintain adequate oxygenation. The FiO2 can be set from a level of 21% to a level of 100%. Usually, patients in acute respiratory distress who are on high flow may initially require a high level of FiO2 to maintain an appropriate saturation. Next is the flow setting. The flow is usually set to try to meet or exceed the patient's inspiratory flow demand. This is challenging because it's difficult to determine what the patient's inspiratory flow is. We learned in the previous video that at rest, when the patient isn't in respiratory distress, the typical inspiratory flow of an adult is around 20 to 30 liters per minute. But for patients in distress, their flow demand will likely be higher. So clinicians often titrate the flow according to the patient's respiratory rate. In other words, the faster the patient is breathing, the more flow they'll probably need.
So I think we should just stop the video for a second here because this is a really good point to make, that the flow rate on the high flow oxygen therapy devices can be set up to 40 liters per minute on some devices and up to 60 liters on other devices. And that when we are breathing at rest, we are breathing 20 to 30 liters per minute. But when we have respiratory distress, that flow increases significantly. So as providers, when you're setting the flow rate on your high flow oxygen therapy device, you really need to evaluate your patient's respiratory rate. Since we cannot directly measure the flow at which our patients are breathing, we use respiratory rate as a surrogate to let us know how quickly or slowly they're breathing. So if a patient has a really high respiratory rate and increased work of breathing, they're going to likely need a higher flow rate. So that's an important concept.
So if you're using the Vapotherm's precision flow device, the highest flow that you can set is 40 liters per minute. On other devices like the Ervo2, they can go as high as 60 liters per minute, and still others can go higher. So these two settings, the flow and FiO2, are the two settings available to the clinician to treat the patient in respiratory distress. If the respiratory rate or the CO2 on the arterial blood gas cannot be corrected or stabilized despite a relatively high flow rate setting, you may need to escalate to non-invasive ventilation or even intubation, depending on the severity of the hypercapnia. Likewise, if the pulse ox or the PaO2 on the arterial blood gas cannot be corrected and stabilized despite a relatively high FiO2 setting, then be prepared to escalate to non-invasive ventilation or even intubation, depending on the severity of the respiratory failure and the diagnosis of the patient.
So another key concept, Dr. Julia, do you want to point out the differences in high flow oxygen therapy for hypoxemia versus hypercarbia?
Sorry, the way those two are treated differently?
Yeah, just whether or not high flow oxygen therapy is an appropriate device for hypercapnia.
Certainly, yeah. When a little later on, we'll talk about the definitions of the different forms of respiratory support that are non-invasive, but the high flow devices really are intended for hypoxemic respiratory failure, levels of low oxygen. As we talked about before, there is a small amount of dead space washout that happens with the high flow devices. And so that can help eliminate some carbon dioxide and contribute a little bit to correction of PCO2, but it's not the most targeted therapy. In order to treat hypercarbic respiratory failure, which is ventilatory failure, you really need to have a different device.
Great, thank you so much. So if you have retention of CO2 and or your oxygenation is not improving with high flow oxygen therapy, then you need to consider a different device.
Whatever you do, do not delay escalation if the patient does not improve with high flow oxygen. Okay, now remember, because there are no patient alarms and data monitoring is not available on high flow oxygen devices, regular patient monitoring is critical. There is one more control in high flow therapy, and that's the temperature setting. To ensure that the high flow of oxygen is tolerable, heat and humidification should be provided. The exact appropriate temperature setting is debatable, and there currently exists no temperature standard. Some suggest to start at 37 degrees Celsius, others suggest start lower. But the key point in temperature setting is to adjust the temperature based on patient comfort and tolerance. Which patients should high flow therapy be placed on? It's still a bit unclear, but we tend to see good outcomes in patients with what we call de novo hypoxemic respiratory failure. De novo hypoxemic respiratory failure is defined as significant hypoxemia, but in the absence of chronic lung disease such as COPD. We also do not include the kind of respiratory failure that occurs in the immediate postoperative or post-extubation period. Remember, high flow therapy can deliver a high FiO2 at a high flow rate, so we anticipate it to be beneficial for hypoxemic patients. However, if a patient presents with acute hypercapnic respiratory failure, which is exhibited by an abnormally high CO2 and a corresponding abnormally low pH, then clinicians may want to consider an alternative form of intervention, such as NIV. Well, what about you? How have you seen high flow therapy used? Leave your
Okay, wonderful. So Jean-Claude, are you still with us? So the next question is to list the indications for high flow oxygen therapy. And you can see here that we have a figure that reviews some articles on when high flow nasal cannula is indicated and when it is not recommended. And the only strong recommendation, as mentioned in the video, is for hypoxemic respiratory failure. It's not indicated necessarily for hypercapnic respiratory failure or when you have a respiratory acidosis. So high flow oxygen therapy will not help with ventilation or elimination of carbon dioxide. There are some conditional recommendations in patients following extubation or in postoperative obese patients following cardio or thoracic surgery. Those are conditional recommendations. And they don't have enough evidence to actually make a recommendation in the peri-intubation period, which means using high flow oxygen therapy for pre-oxygenation. So the only strong indication for is for hypoxemic respiratory failure. Okay, so if you want to learn more about high flow oxygen therapy, in addition to the videos that we've shared on the Learning Resource Center, we do have 4 other resources that you are welcome to read on your own. Up to Date has a good summary of indications of high flow nasal cannula that's been updated just this year. Curious also has a discussion about mechanisms of action in adult and pediatric indications for high flow oxygen therapy from 2018. The American Thoracic Society also has evidence-based assessment of high flow oxygen therapy from 2017. And then a really good article from the International Journal of Critical Care and Emergency Medicine details some things to keep in mind when using high flow therapy for providers. So it's more like a guideline, which is great. So those you can read on your own. And next, I'm going to ask Shelley again to help us with this next poll question. Shelley?
Okay, here I am.
Okay. Okay, thanks.
Okay.
So let's go ahead and read this next question and have the audience answer either in the chat box or using the poll.
Okay. Which one of the following is incorrect regarding the parameters set by providers when delivering high flow oxygen therapy? A, providers can use respiratory rate to estimate the initial flow setting needed on the high flow device. B, providers can directly measure the flow at which a patient is breathing and match their inspiratory flow demand using the high flow device. C, the average inspiratory flow of an adult breathing at rest is approximately 20 to 30 liters per minute. D, the flow rate set on the high flow device should attempt to meet or exceed the patient's inspiratory flow demand. And or E, inspiratory flow demand increases during respiratory distress. So again, which one of the following is not right, is incorrect regarding the parameters set by providers when delivering high flow oxygen therapy? So if you guys would answer in the chat box.
Or in the poll.
Or in the poll, please.
Great. So we have a lot of people answering the letter B in the chat box, and in the poll, I see that's the most popular answer as well. Okay. Wonderful. So I think this is a great question. I'm going to end the poll, Shelley, if that's okay with you. So B is the most popular answer, and that's also what we saw in the chat box. So that's great, and that is correct answer. Or the incorrect answer. So I think, yeah, so Shelley, I think this is an important question because if B is incorrect, that means all the other options are correct. So we can, as providers, use the respiratory rate just to estimate the initial flow setting needed. And the average inspiratory flow, as we've mentioned, or as you've mentioned, Shelley, is 20 to 30 liters per minute, just breathing at rest. So when you're setting up your high flow oxygen therapy device, Shelley, what flow do you normally start with?
Well, we know that the max flow on some devices is 40 liters a minute, and others is 60 liters a minute. Excuse me, sorry. Normally, so we want to exceed or meet the normal inspiratory flow. Well, that actually, excuse me, that's not true. They do have a higher demand. They are in need of more flow because they're in respiratory distress. Normally, personally, I start at about 30 and look at them, and I look at their degree of distress. Has it gone down? Do they look more comfortable? And I'll go up from there.
Describe that as an improvement in either work of breathing or respiratory rate. Is that fair?
Yeah. Exactly. I start at 30, stand at the bedside, have a look at them, and 40 is a good starting point as well.
Okay. And so you monitor them for improvement, which is what everyone does. So once you put them on the high flow oxygen therapy, if they don't have an improvement in work of breathing or respiratory rate, you either go up on the flow, or what if you're at your max flow and they're not improving?
Well, it's time to escalate to a different device. We can try either NIV, or if things are real bad, it's time to intubate.
Okay, great. Thank you. Do you want to help us cover this next question as well, Shelley?
Sure. In which of the following scenarios would providers need to escalate care from a high flow nasal cannula setup? Oops, the pole got in my way, excuse me.
Okay, that's the same.
Sorry, to escalate care from high flow to either, NIV, also called NIPPV, or intubation with mechanical ventilation. A, respiratory rate does not correct or stabilize despite receiving high flow rates with the high flow nasal cannula. B, the patient's partial pressure of CO2 remains elevated or worsens on ABG, arterial blood gas analysis, despite receiving high flow rates on the high flow nasal cannula device. C, the SpO2 or oxygen saturation does not correct or stabilize despite receiving high FiO2 on the high flow device. D, the PaO2 does not correct or stabilize despite receiving high flow on the high flow nasal cannula device. Or E, all of the above should lead to escalation of care without delay.
I'm seeing in the poll and the chat box that everyone is getting this correct, which is fantastic.
I agree. Yes.
Good. So the biggest threat to the patient is a delay in escalation when your intervention has failed. So it's really important for us to recognize when our interventions fail so that we can escalate care appropriately. Wonderful. So everyone answered correctly, which is great. Okay, so we're going to ask Freddie to help us with this next question here. Dr. Freddie, are you still with us?
Oh, yes.
Wonderful. Why don't you take us through this next topic?
Okay. We want to talk about the ROX index. How can I help clinical providers? I have to say that ROX index is a very useful tool created by an intensivist critical care specialist from Spain, Dr. Roca. And Dr. Roca write a paper of
on the question box, and it actually takes you to a calculator, so we can walk through this with Dr. Freddie.
Oh, yes. Yes, Dr. Roca with the ROX index try to help to guide clinicians in what type of patients has a high risk to need a subsequent endotracheal intubation. So in the original paper, Dr. started on high-flow nasal cannula, and reassessments at 2, 6, and 12 hours were done in patients. And those patients with low scores were classified as high risk patients, and were in the terminate range between 3.85 and 4.87 were reassessed because they were in a gray or indeterminate range, and were reassessed 2 hours later. This is a very important and simple tool that is used after high-flow nasal cannula is used, and during reassessment. The ROX index can help suggest which patients will fail high-flow nasal cannula and need to progress to intubation for further ventilatory support. A higher index is better, and it suggests a better oxygen saturation, a lower fraction of inspired oxygen requirement. So, and less tachypnea, obviously. While not externally validated, the ROX index is a simple bedside calculation using 3 clinical variables, and is one easy way to summarize a patient degree of hypoxemic respiratory failure. So this is very useful. In this patient, we had a respiratory rate of saturation, pulse oximetry of 90%.
Okay, I'll type it in.
May you write, Dr. Anna?
Yeah, no problem.
90%. Fraction inspired of oxygen of 100%, and respiratory rate of 35. So
Okay.
our index is 2.57. So this is a patient of high risk to end in an intubation. Probably is a patient that has to be escalated rapidly.
Okay, wonderful. Thank you, Dr. Freddy. So this is just one way for providers to estimate the risk or identify failure with high flow oxygen therapy. And so you can escalate your care if the ROX index is closer to 2. So, all right, so let's check in with Mr. G. He's still on high flow oxygen therapy, and we just plugged these settings into the ROX calculator, the ROX index, and it says that he's not doing very well. So the bedside team decides to try non-invasive positive pressure ventilation. So I want to move on to our next topic, non-invasive positive pressure ventilation. And again, remind providers that this is an aerosol generating intervention, so that providers must be in PPE. You must wear contact, droplet, and airborne precaution PPE. Our next practice change objectives related to non-invasive positive pressure: list the indications for non-invasive positive pressure ventilation for acute respiratory failure, list the benefits, and list the complications of non-invasive. So our first question is, what is the difference between NIV, NIPPV, Cpap, and BiPAP? And this is a very common question, and I think there's some confusion. So if we click on this question, you can see that it's a frequently asked question on opencriticalcare.org, which is another great resource for you that's free and open access. And so you can see the question here. And Julia, would you mind helping to read the differences between these?
Sure, and yeah, the terminology could be confusing. I'm actually just going to read, these definitions on here are very well written, so I'm just going to read those for you all. The first most simple one is Cpap, continuous positive airway pressure. And those devices apply constant pressure throughout the respiratory cycle, either through a face mask or some other interface, like a ventilator, for example, to help splint open the upper airway, which increases lung volume and increases intrathoracic pressure. So Cpap provides no inspiratory muscle unloading, and tidal ventilation remains completely dependent on the respiratory muscles or the patient effort. It just supports the patient's own effort. On the other hand, non-invasive ventilation or non-invasive positive pressure ventilation, and those two terms can be used interchangeably, that applies 2 levels of pressure during the respiratory cycle. So a certain pressure during the inspiratory phase that is greater than the pressure applied during exhalation. So this is effectively mechanical ventilation, and this does unload the effort that the respiratory muscles are making, and it can provide complete respiratory support. And BiPAP, which is bi-level positive airway pressure, it's just a brand name that basically is the same as non-invasive ventilation or non-invasive positive pressure ventilation. It's just that a certain company decided to make that their special term. So that's all that BiPAP means.
Great, thank you so much.
Yeah.
Okay, I just wanted to point out that non-invasive ventilatory support can be used in patients with acute or chronic respiratory failure. Chronic respiratory issues include COPD, neuromuscular disorders, chest wall diseases, obstructive sleep apnea, obesity, hypoventilation syndrome, and we're not discussing those during this session. We're talking about acute respiratory failure only. And so I'm going to go ahead and move on to another short video on CPAP and non-invasive ventilation. So we'll watch this video.
Hello, my name is Nick, and in this video we're going to look at CPAP, continuous positive airway pressure, and non-invasive ventilation, also known as BiPAP, biphasic positive airway pressure. CPAP is a way of keeping the pressure positive in a spontaneously breathing patient's lungs. This positive pressure helps keep the smaller airways and alveoli open, which allows for additional gas exchange to take place by recruiting areas of a lung that might otherwise have collapsed down. A tight mask is applied to the patient's face to create a seal. Air and oxygen now flow through a circuit attached to the mask at high flow. The patient exhales through a valve which closes when the desired pressure is achieved. This pressure created by the valve is known as Peep, positive end expiratory pressure. It's this that leads to pressure in the patient's lungs at the end of expiration. There are several types of masks that can be used: oral masks, nasal masks, full face masks, and CPAP hoods. CPAP has been shown to be particularly useful in acute cardiogenic pulmonary edema and congestive heart failure, where in simple terms, the positive pressure created helps push the fluid out of the lungs and into the circulation and prevents further fluid coming back into the lungs. It can also be used for pneumonia, sleep apnea, and atelectasis. So what is non-invasive ventilation? Sometimes just keeping the alveoli open isn't enough, especially if the patient develops type 2 respiratory failure and starts to retain carbon dioxide. Think of non-invasive ventilation as CPAP with added zing. Non-invasive ventilation is used to increase the size of each breath taken by the patient. It gives an assisted push behind the breath, which increases its size and thus reduces carbon dioxide levels by blowing off CO2. It seems to be most useful in conditions such as exacerbation of COPD and post-extubation on ITU. Similar success has been reported with asthma patients as well as certain other respiratory conditions where there may be reluctance to sedate, intubate and ventilate a patient due to existing risk factors. So how does non-invasive ventilation work? As with Cpap, a tight-fitting mask is fitted to the patient's face, but this time the patient breathes through a mechanical ventilator. On the ventilator, two pressures are set. Firstly, the positive end expiratory pressure, Peep, similar to that used in Cpap. As before, this pressure helps preventing the alveoli from collapsing. Secondly, the pressure that creates the push. This is the inspiratory pressure, which increases the size of each breath or tidal volume. The bigger the pressure, the bigger the push, the bigger the tidal volume. So let's assume that we set the Peep at 10 centimeters of water. The pressure in the patient's lungs will not drop below this level. It's now the baseline pressure, if you like. Now assume we set the inspiratory pressure at 15 centimeters of water. Note that the inspiratory pressure is added on top of the Peep. As the patient takes the breath, it causes the ventilator to initiate. It now increases the pressure until the inspiratory pressure is achieved. Once the inspiratory pressure has been reached, the expiratory valve opens, the pressure begins to fall, and the patient exhales passively until the pressure drops back to the Peep level, where the valve closes to maintain the pressure. The inspiratory pressure can be adjusted until the desired tidal volume has been achieved, usually about 6 to 8 mils per kilogram. In addition to the pressures in both non-invasive ventilation and Cpap, oxygen levels must be set. For various reasons, this is frequently referred to as the Fio2 or fraction of inspired oxygen. The Fio2 is expressed as a fraction so that 100% oxygen is expressed as an Fio2 of 1 and 21% oxygen is expressed as an Fio2 of 0.21.
Okay, we'll stop there. And if you don't mind, Dr. Julia, I'm going to ask you again to help us with this next question.
Sure. So there are two conditions leading to acute respiratory failure in adult patients that have very strong evidence of benefit from non-invasive positive pressure ventilation. What are they? And I think I'll just say them since they're already shown here and in the interest of time. So the two main ones are acute exacerbation of COPD and acute cardiogenic pulmonary edema. So COPD bilevel is preferred because oftentimes these people have hypoxic and hypercarbic respiratory failure. So you need a little help in helping them blow off the extra carbon dioxide for their hypercapnia. So bilevel or the two pressure system is preferred. It has been shown to reduce mortality in these patients and reduce rates of intubation, and it has reduced length of hospital stay. And then for acute cardiogenic pulmonary edema, Cpap is preferred. BiPAP can be useful too, but the continuous positive airway pressure just helps keep that fluid from leaking more into the alveoli, as the video said. It has been shown to reduce rates of intubation. It reduces dyspnea, so the patient's subjective experience of uncomfortable breathing, and it's been shown to reduce mortality. Now, certainly we use non-invasive ventilation for many other situations, as we've talked about a little bit, but it has not been shown to improve mortality or to improve outcomes, even though everyone strongly suspects that it has a lot of benefit. These are the two situations that it has been shown to have evidence-based benefit. So that's why it's worth highlighting them.
So I have a question for all of the panelists here today. When our learners register for this session, they're able to submit questions. And most of the questions were already built into the session. But there was one question that we haven't talked about in our session that I wanted to see if the panelists could help me answer. And that was the use of the Cpap helmets. I have used the Cpap masks, the nasal masks, the oral nose and mouth masks, and the full face masks. but I have never used the Cpap helmet. My experience has been limited because it's frankly not available in the institutions in which I work, but I wanted to see if anyone else had any experience with the Cpap helmet.
It's not available at my institutions either. I've seen it used just as a demonstration, so I've never seen it used in clinical care. The reports I hear from folks I know that work at places where it is available is that it works very well. It's much more comfortable for the patients, and so they can tolerate it much better. One of the specific patients that has a hard time with CPAP or with BiPAP is someone who's a little bit confused or a little bit delirious or a little bit agitated, because they just have a really hard time keeping that mask on in the right spot. It makes them feel panicky, it makes them feel more confused. And I've been told that the helmet is really great in those situations because it's much more comfortable and people don't have the tendency to keep trying to take it off.
And what sort of pressures are generated by that helmet, Julia? Do you know how high the pressure can go with that type of device?
I don't know. Yeah, I don't know the numbers.
I don't know neither.
Okay.
I don't know. We have no use.
Sorry, Freddie, go ahead.
No, I was saying that we have no experience on helmets and non-invasive pressure, but it seems that some outcomes in some studies are better than the mask non-invasive ventilation. So we have to wait for more evidence.
Yeah. It looks like it's not available in Rwanda either, according to Jean-Claude's response. I think that one added benefit that I can imagine is that it would also contain aerosol. So if there was, a viral infection that could lead to the aerosolization, that hood might be more protective and better for providers. But that's just a guess. I don't know that we have evidence of that. I'm going to ask our colleague Radia to help us list some contraindications to non-invasive positive pressure.
So hello again, everyone. So contraindications to NIPPV or non-invasive positive pressure ventilation. There are absolute contraindications. And if you can, yeah, thank you.
Mm-hmm.
So there are absolute contraindications and there are relative contraindications. So the absolute contraindications to NIPPV include urgent need for intubation and mechanical ventilation. For example, in the presence of cardiac arrest or respiratory arrest, that case, the patient cannot be on non-invasive positive pressure ventilation. The second one, which is a relative contraindication, include facial or neurologic surgery, trauma, or deformities. That way, a tight-fitting mask or the devices that connect to the machine cannot be tightly fit into the patient. Upper GI bleeding or active MSs that can intervene with the airways, therefore with the flow of oxygen. This is also a contraindication. If a patient has encephalopathy and if a patient needs the need for prolonged mechanical ventilation is seen, that's also a relative contraindications to non-invasive positive pressure ventilation. And if a patient is uncooperative and is unable to protect his or her airway or is unable to clear their own secretions. That way, since the airway is not protected, then non-invasive positive pressure ventilation might not be the right choice for that patient. And in the presence of obstructed airway as well, may not be the right choice. You have to bypass the obstructed airway to provide the oxygen or the pressure that the patient needs. So in that way, non-invasive positive pressure ventilation is a contraindication.
Wonderful.
Thank you.
Thank you. Thanks so much. Yeah, so the patients that are failing high flow oxygen therapy or have a ROX index, for example, that predicts that they're at high risk of failure, and they have one of these contraindications, you probably would skip the non-invasive positive pressure and go directly to intubation and mechanical ventilation, wouldn't you say? Okay, we have another case update. Mr. G is placed on non-invasive positive pressure for 1 hour. His pressure support ventilation or inspiratory pressure is set at 15 and his Peep is set at 5. His FiO2 is set at 100%. His respiratory rate remains at 35 breaths per minute. He appears fatigued and he is slumped over in the bed and arouses only with shaking. I'd like to ask the audience, what is the appropriate next step in Mr. G's care? And you can put your answers in the chat box. What would you do next for this patient? What is the next step in treating his hypoxemia?
Great. People must hear. That's the next step.
Yeah, panelists, what do you think about these answers in the chat box? 2 thumbs up from Julia, 2 thumbs up from
Not
Shelley.
waste.
Yeah, everybody is not wasting time. They are not waiting for their patients to get worse. They're intubating and placing on mechanical ventilation. Perfect. There are a lot of different non-invasive positive pressure and Cpap devices out there. And if you want more information about how to set them up, for example, you get a machine or a circuit that you're with which you're unfamiliar, you can go to opencriticalcare.org. You can go directly to that website, or you can click on this link on the Learning Resource Center. And it gives you descriptions of different types of masks and circuits and helps you go through setting them up. This concludes our session. I think for the very first time, we're actually on time, which I can't believe. It's wonderful. The best way to find yourself is to lose yourself in the service of others. I want to thank all of our amazing panelists. Thank you so much for sharing your time and your expertise with us. And I've now opened it up for a couple questions with the last 4 to 5 minutes, or comments from the panelists about high flow oxygen and non-invasive.
I have a comment about non-invasive real quick, and that is it's highly dependent upon the fit of the mask. So if you're using a face mask with your non-invasive, you can't have a lot of air seeping out because you won't get a good tight seal and your results will not be what you want. It's uncomfortable. Yeah. And so the flow will.
For those of us who have used CPAP or non-invasive ventilation masks on our patients, we have seen that when it doesn't work. And essentially, in order for that pressure to be translated to the lungs themselves, that seal on the mask has to be intact. If you have a leak around the mask, then the pressure won't be transmitted to the lungs and airway. So that's absolutely correct. Yeah.
Well said. Thank you.
Yeah. Any other points, learning points from our panelists about either of these therapeutic devices or interventions? Okay, I think we're going to conclude with a poll about our translations. Part of it is definitely some of the videos. The English is very fast, even for me, and I'm a native English speaker. So if the translators did not do perfectly, please forgive them. I tried to slow down the videos for them. I want to thank all of our learners, all of our panelists, and mostly our partners, Assist International and Project ECHO, for making all of this possible and getting education around the globe. So thank you all very much.
Bye-bye.